7. Hard Conversations. Traveling abroad sometime afterward, I fell into a conversation with two doctors from Uganda and a writer from South Africa. I told them about Sarah's case and asked what they thought should have been done for her. To their eyes, the choices we offered her seemed extravagant. Most people with terminal illness in their countries would never have come to the hospital, they said. Those who did would neither expect nor tolerate the extremes of multiple chemotherapy regimens, last-ditch surgical procedures, experimental therapies, when the problem's ultimate outcome was so dismally clear, and the health system wouldn't have the money for it. But then they couldn't help but talk about their own experiences, and their tales sounded familiar. A grandparent put on life support against his wishes, a relative with incurable liver cancer who died in the hospital on an experimental treatment, a brother-in-law with a terminal brain tumor who nonetheless endured endless cycles of chemotherapy that had no effect except to cut him down further and further. Each round was more horrible than the last, the South African writer told me. I saw the medicine eat his flesh. The children are still traumatized. He could never let go. Their countries were changing. 5 of the 10 fastest-growing economies in the world are in Africa. By 2030, 1/2 to 2/3 of the global population will be middle class. Vast numbers of people are becoming able to afford consumer goods like televisions and cars, and health care. Surveys in some African cities are finding, for example, that half of the elderly over 80 years old now die in the hospital, and even higher percentages of those less than 80 years old do. These are numbers that actually exceed those in most developed countries today. Versions of Sarah's story are becoming global. As incomes rise, private sector healthcare is increasing rapidly, usually paid for in cash. Doctors everywhere become all too ready to offer false hopes, leading families to empty bank accounts, sell their seed crops, and take money from their children's education for futile treatments. Yet at the same time, hospice programs are appearing everywhere from Kampala to Kinshasa, Lagos to Lesotho, not to mention Mumbai to Manila. Scholars have posited 3 stages of medical development that countries go through, paralleling their economic development. In the first stage, when a country is in extreme poverty, most deaths occur in the home because people don't have access to professional diagnosis and treatment. In the second stage, when a country's economy develops and its people transition to higher income levels, the greater resources make medical capabilities more widely available. People turn to healthcare systems when they are ill. At the end of life, they often die in the hospital instead of the home. In the third stage, as a country's income climbs to the highest levels, people have the means to become concerned about the quality of their lives, even in sickness, and deaths at home actually rise again. This pattern seems to be what is happening in the United States. Whereas deaths in the home went from a clear majority in 1945 to just 17% in the late 80s, since the 90s, the numbers have reversed direction. Use of hospice care has been growing steadily, to the point that by 2010, 45% of Americans died in hospice. More than half of them received hospice care at home, and the remainder received it in an institution, usually an inpatient hospice facility for the dying, or a nursing home. These are among the highest rates in the world. A monumental transformation is occurring. In this country and across the globe, people increasingly have an alternative to withering in old age homes and dying in hospitals, and millions of them are seizing the opportunity. But this is an unsettled time. We've begun rejecting the institutionalized version of aging and death, but we've not yet established our new norm. We're caught in a transitional phase. However miserable the old system has been, we are all experts at it. We know the dance moves. You agree to become a patient, and I, the clinician, agree to try to fix you, whatever the improbability, the misery, the damage, or the cost. With this new way in which we together try to figure out how to face mortality and preserve the fiber of a meaningful life with its loyalties and individuality, we are plodding novices. We are going through a societal learning curve, one person at a time, and that would include me, whether as a doctor or as simply a human being. My father was in his early 70s when I was forced to realize that he might not be immortal. He'd been as healthy as a Brahma bull, playing tennis 3 days a week, maintaining a busy urology practice, and serving as president of the local Rotary Club. He had tremendous energy. He did numerous charity projects, including working with a rural Indian college he'd established, expanding it from a single building to a campus with some 2,000 students. Whenever I came home, I'd bring my tennis rackets and we'd go out on the local courts. He played to win, and so did I. He'd drop-shot me. I'd drop-shot him. He'd lob me. I'd lob him. He had picked up a few old man habits, like blowing his nose onto the court whenever he felt like it, or making me chase down our errant tennis balls. But I took them to be the kinds of advantages a father takes with a son, rather than signs of age. In more than 30 years of medical practice, he'd not canceled his clinic or operating schedule for sickness once. So when he mentioned the development of a neck pain that shot down his left arm and caused tingling in the tips of his left fingers, neither one of us was inclined to think too much of it. An X-ray of his neck showed only arthritis. He took anti-inflammatory medication, underwent physical therapy, and took a break from using an overhead serve, which exacerbated the pain. Otherwise, it was life as usual for him. Over the next couple years, however, the neck pain progressed. It became difficult for him to sleep comfortably. The tingling in the tips of his left fingers became full-blown numbness and spread to his whole left hand. He found he had trouble feeling the thread when tying sutures during vasectomies. In the spring of 2006, his doctor ordered an MRI of his neck. The findings were a complete shock. The scan revealed a tumor growing inside his spinal cord. That was the moment when we stepped through the looking glass. Nothing about my father's life and expectations for it would remain the same. Our family was embarking on its own confrontation with the reality of mortality. The test for us as parents and children would be whether we could make the path go any differently for my dad than I, as a doctor, had made it go for my patients. The number 2 pencils had been handed out. The timer had been started. But we had not even registered that the test had begun. My father sent me the images by email, and we spoke by phone as we looked at them on our laptops. The mass was nauseating to behold. It filled the entire spinal canal, extending all the way up to the base of his brain and down to the level of his shoulder blades. It appeared to be obliterating his spinal cord. I was amazed that he wasn't paralyzed, that all the thing had done so far was make his hand numb and his neck hurt. We didn't talk about any of this, though. We had trouble finding anywhere safe for conversation to take purchase. I asked him what the radiologist's report said the mass might be. Various benign and malignant tumors were listed, he said. Did it suggest any other possibilities besides a tumor? Not really, he said. 2 surgeons, we puzzled over how a tumor like this could be removed. But there seemed no way, and we grew silent. Let's talk to a neurosurgeon before jumping to any conclusions, I said. Spinal cord tumors are rare, and few neurosurgeons have much experience with them. A dozen cases is a lot. Among the most experienced neurosurgeons was one at the Cleveland Clinic, which was 200 miles from my parents' home, and one at my hospital in Boston. We made appointments at both places. Both surgeons offered surgery. They would open up the spinal cord, I didn't even know that was possible, and remove as much of the tumor as they could. They'd only be able to remove part of it, though. The tumor's primary source of damage was from its growth inside the confined space of the spinal canal. The beast was outgrowing its cage. The expansion of the mass was crushing the spinal cord against the vertebral bone, causing pain as well as destruction of the nerve fibers that make up the cord. So both surgeons proposed also doing a procedure to expand the space for the tumor to grow. They'd decompress the tumor by opening the back of the spinal column and stabilize the vertebra with rods. It'd be like taking the back wall off a tall building and replacing it with columns to hold up the floors. The neurosurgeon at my hospital advocated operating right away. The situation was dangerous, he told my father. He could become quadriplegic in weeks. No other options existed. Chemotherapy and radiation were not nearly as effective in stopping progression as surgery. The operation had risks, he said, but he wasn't too worried about them. He was more concerned about the tumor. My father needed to act before it was too late. The neurosurgeon at the Cleveland Clinic painted a more ambiguous picture. While he offered the same operation, he didn't push to do it right away. He said that while some spinal cord tumors advanced rapidly, he'd seen many take years to progress, and they did so in stages, not all at once. He didn't think my father would go from a numb hand to total paralysis overnight. The question, therefore, was when to go in, and he believed that should be when the situation became intolerable enough for my father to want to attempt treatment. The surgeon was not as blithe about its risks as the other neurosurgeon. He thought it carried a 1 in 4 chance of itself causing quadriplegia or death. My father, he said, would need to draw a line in the sand. Were his symptoms already bad enough that he wanted surgery now? Would he want to wait until he started to feel hand symptoms that threatened his ability to do surgery? Would he want to wait until he couldn't walk? The information was difficult to take in. How many times had my father given patients bad news like this, that they had prostate cancer, for instance, requiring similarly awful choices to be made? How many times had I done the same? The news, nonetheless, came like a body blow. Neither surgeon came out and said that the tumor was fatal, but neither said the tumor could be removed either. It could only be decompressed. In theory, a person should make decisions about life and death matters analytically, on the basis of the facts, but the facts were shot through with holes and uncertainties. The tumor was rare. No clear predictions could be made. Making choices required somehow filling the gaps, and what my father filled them with was fear. He feared the tumor and what it would do to him, and he also feared the solution being proposed. He could not fathom opening up the spinal cord, and he found it difficult to put his trust in any operation that he did not understand, that he did not feel capable of doing himself. He asked the surgeons numerous questions about how exactly it would be done. What kind of instrument do you use to enter the spinal cord, he asked. Do you use a microscope? How do you cut through the tumor? How do you cauterize the blood vessels? Couldn't the cautery damage the nerve fibers of the cord? We use such and such an instrument to control prostate bleeding in urology. Wouldn't it be better to use that? Why not? The neurosurgeon at my hospital didn't much like my father's questions. He was fine answering the first couple, but after that he grew exasperated. He had the air of the renowned professor he was, authoritative, self-certain, and busy with things to do. Look, he said to my father, the tumor was dangerous. He, the neurosurgeon, had a lot of experience treating such tumors. Indeed, no one had more. The decision for my father was whether he wanted to do something about his tumor. If he did, the neurosurgeon was willing to help. If he didn't, that was his choice. When the doctor finished, my father didn't ask any more questions, but he'd also decided that this man wasn't going to be his surgeon. The Cleveland Clinic neurosurgeon, Edward Benzel, exuded no less confidence, but he recognized that my father's questions came from fear. So he took the time to answer them, even the annoying ones. Along the way, he probed my father, too. He said that it sounded like he was more worried about what the operation might do to him than what the tumor would. My father said he was right. My father didn't want to risk losing his ability to practice surgery for the sake of treatment of uncertain benefit. The surgeon said that he might feel the same way himself in my father's shoes. Benzel had a way of looking at people that let them know he was really looking at them. He was several inches taller than my parents, but he made sure to sit at eye level. He turned his seat away from the computer and planted himself directly in front of them. He did not twitch or fidget or even react when my father talked. He had that Midwesterner's habit of waiting a beat after people have spoken before speaking himself in order to see if they are really done. He had small dark eyes set behind wire-rimmed glasses and a mouth hidden by the thick gray bristle of a Van Dyke beard. The only thing to hint at what he was thinking was the wrinkle of his glossy dome of a forehead. Eventually, he steered the conversation back to the central issue. The tumor was worrisome, but he now understood something about my father's concerns. He believed my father had time to wait and see how quickly his symptoms changed. He could hold off surgery until he felt he needed it. My father decided to go with Benzel and his counsel. My parents made a plan to return in a few months for a checkup and to call sooner if he experienced any signs of serious change. Did he prefer Benzel simply because he'd portrayed a better, at least slightly less alarming picture of what might happen with the tumor? Maybe. It happens. Patients tend to be optimists, even if that makes them prefer doctors who are more likely to be wrong. Only time would tell which of the two surgeons was right. Nonetheless, Benzel had made the effort to understand what my father cared about most, and to my father, that counted for a lot. Even before the visit was halfway over, he had decided Benzel was the one he would trust. In the end, Benzel was also the one who proved right. As time passed, my father noticed no change in symptoms. He decided to put off the follow-up appointment. It was ultimately a year before he returned to see Benzel. A repeat MRI showed the tumor had enlarged, yet physical examination found no diminishment in my dad's strength, sensation, or mobility, so they decided to go primarily by how he felt, not by what the pictures looked like. The MRI reports would say haunting things, like the imaging demonstrates significant increase in size of the cervical mass at the level of the medulla and midbrain. But for months at a stretch, nothing occurred to change anything relevant for how he lived. The neck pain remained annoying, but my father figured out the best positions for sleeping at night. When chilly weather came, he found that his numb left hand became bone cold. He took to wearing a glove over it, Michael Jackson style, even indoors at home. Otherwise, he kept on driving, playing tennis, doing surgery, living life as he had been. He and his neurosurgeon knew what was coming, but they also knew what mattered to him and left well enough alone. This was, I remember thinking, just the way I ought to make decisions with my own patients, the way we all ought to in medicine. During medical school, my fellow classmates and I were assigned to read a short paper by two medical ethicists, Ezekiel and Linda Emanuel, on the different kinds of relationships that we, as budding new clinicians, might have with our patients. The oldest, most traditional kind is a paternalistic relationship. We are medical authorities aiming to ensure that patients receive what we believe best for them. We have the knowledge and experience. We make the critical choices. If there were a red pill and a blue pill, we would tell you, take the red pill. It will be good for you. We might tell you about the blue pill, but then again, we might not. We tell you only what we believe you need to know. It is the priestly doctor knows best model, and although often denounced, it remains a common mode, especially with vulnerable patients, the frail, the poor, the elderly, and anyone else who tends to do what they're told. The second type of relationship the authors termed informative. It's the opposite of the paternalistic relationship. We tell you the facts and figures, the rest is up to you. Here's what the red pill does, and here's what the blue pill does, we would say. Which one do you want? It's a retail relationship. The doctor is the technical expert. The patient is the consumer. The job of doctors is to supply up-to-date knowledge and skills. The job of patients is to supply the decisions. This is the increasingly common way for doctors to be, and it tends to drive us to become ever more specialized. We know less and less about our patients, but more and more about our science. Overall, this kind of relationship can work beautifully, especially when the choices are clear, the trade-offs are straightforward, and people have clear preferences. You get only the tests, the pills, the operations, the risks that you want and accept. You have complete autonomy. The neurosurgeon at my hospital in Boston showed elements of both these types of roles. He was the paternalistic doctor. Surgery was my father's best choice, he insisted, and my father needed to have it now. But my father pushed him to try to be the informative doctor, to go over the details and the options. So the surgeon switched. But the descriptions only increased my father's fears, fueled more questions, and made him even more uncertain about what he preferred. The surgeon didn't know what to do with him. In truth, neither type is quite what people desire. We want information and control, but we also want guidance. The Emmanuels described a third type of doctor-patient relationship, which they called interpretive. Here, the doctor's role is to help patients determine what they want. Interpretive doctors ask, "What is most important to you? What are your worries?" Then, when they know your answers, they tell you about the red pill and the blue pill and which one would most help you achieve your priorities. Experts have come to call this shared decision-making. It seems to us medical students a nice way to work with patients as physicians, but it seemed almost entirely theoretical. Certainly to the larger medical community, the idea that most doctors would play this kind of role for patients seemed far-fetched at the time. Surgeons? Interpretive? Ha! I didn't hear clinicians talk about the idea again and largely forgot about it. The choices in training seemed to be between the more paternalistic style and the more informative one. Yet less than 2 decades later, here we were with my father in a neurosurgeon's office in Cleveland, Ohio, talking about MRI images showing a giant and deadly tumor growing in his spinal cord, and this other kind of doctor, one willing to genuinely share decision-making, was precisely what we found. Benzel saw himself as neither the commander nor a mere technician in this battle, but instead as a kind of counselor and contractor on my father's behalf. It was exactly what my father needed. Rereading the paper afterward, I found the author's warning that doctors would sometimes have to go farther than just interpreting people's wishes in order to serve their needs adequately. Wants are fickle, and everyone has what philosophers call second-order desires, desires about our desires. We may wish, for instance, to be less impulsive, more healthy, less controlled by primitive desires like fear or hunger, more faithful to larger goals. Doctors who listen to only the momentary first-order desires may not be serving their patients' real wishes after all. We often appreciate clinicians who push us when we make short-sighted choices, such as skipping our medications or not getting enough exercise, and we often adjust to changes we initially fear. At some point, therefore, it becomes not only right, but also necessary for a doctor to deliberate with people on their larger goals, to even challenge them to rethink ill-considered priorities and beliefs. In my career, I have always been most comfortable being doctor informative. My generation of physicians has mostly steered away from being doctor knows best. But doctor informative was clearly not sufficient to help Sarah Monopoli or the many other seriously ill patients I'd had. Around the time of my father's visits with Benzel, I was asked to see a 72-year-old woman with metastatic ovarian cancer who had come to my hospital's emergency room because of vomiting. Her name was Jewel Douglas, and looking through her medical records, I saw that she'd been in treatment for 2 years. Her first sign of the cancer had been a feeling of abdominal bloating. She saw her gynecologist, who found, with the aid of an ultrasound, a mass in her pelvis the size of a child's fist. In the operating room, It proved to be an ovarian cancer, and it had spread throughout her abdomen. Soft, fungating tumor deposits studded her uterus, her bladder, her colon, and the lining of her abdomen. The surgeon removed both of her ovaries, the whole of her uterus, half of her colon, and a third of her bladder. She underwent 3 months of chemotherapy. With this kind of treatment, most ovarian cancer patients at her stage survive 2 years, and a third survive 5 years. About 20% of patients are actually cured. She hoped to be among these few. She reportedly tolerated the chemotherapy well. She'd lost her hair, but otherwise experienced only mild fatigue. At 9 months, no tumor could be seen on her CT scans at all. At 1 year, however, a scan showed a few pebbles of tumor had grown back. She felt nothing. They were just millimeters in size, but there they were. Her oncologist started a different chemotherapy regimen. This time, Douglas had more painful side effects: mouth sores, a burn-like rash across her body, but with salves of various kinds, they were tolerable. A follow-up scan showed the treatment hadn't worked, though. The tumors grew. They began giving her shooting pains in her pelvis. She switched to a third kind of chemotherapy. This one was more effective. The tumors shrank, the shooting pains went away, but the side effects were much worse. Her records reported her having terrible nausea despite trying multiple medications to stop it. Limb-sapping fatigue put her in bed for hours a day. An allergic reaction gave her hives and intense itching that required steroid pills to control. One day she became severely short of breath and had to be brought to the hospital by ambulance. Tests showed she had developed pulmonary emboli, just as Sarah Monopoli had. She was put on daily injections of a blood thinner and only gradually regained her ability to breathe normally. Then she developed clenching, gas-like pains in her belly. She began vomiting. She found she could not hold anything down, liquid or solid. She called her oncologist, who ordered a CT scan. It showed a blockage in a loop of her bowel caused by her metastases. She was sent from the radiology department to the emergency room. As the general surgeon on duty, I was called to see what I could do. I reviewed the images from her scan with a radiologist, but we could not precisely make out how the cancer was causing her intestinal blockage. It was possible that the bowel loop had gotten caught on a knuckle of tumor and then twisted, a problem that could potentially resolve on its own if given time. Or else the bowel had become physically compressed by a tumor growth, a problem that would resolve only with surgery to either remove or bypass the obstruction. Either way, it was a troubling sign of the advancement of her cancer, despite, now, 3 regimens of chemotherapy. I went to talk to Douglas, thinking about exactly how much of this to confront her with. By this time, a nurse had given her intravenous fluids, and a resident had inserted a 3-foot-long tube into her nose down to her stomach, which had already drained out a half-liter of bile-green fluid. Nasogastric tubes are uncomfortable, torturous devices. People who have the thing stuck into them are usually not in a conversational mood. When I introduced myself, however, she smiled, made a point of having me repeat my name, and made sure she could pronounce it correctly. Her husband sat by her in a chair, pensive and quiet, letting her take the lead. "I seem to be in a pickle, from what I understand," she said. She was the sort of person who'd managed, even with the tube taped into her nose, to fix her hair, which she wore in a bob, put her glasses back on, and smooth her hospital sheets over her neatly. She was doing her best to maintain her dignity under the circumstances. I asked how she was feeling. The tube had helped, she said. She felt much less nauseated. I asked her to explain what she'd been told. She said, "Well, doctor, it seems my cancer is blocking me up, so everything that goes down comes back up again." She'd grasped the grim basics perfectly. At this point, we had no especially difficult decisions to make. I told her there was a chance that this was just a twist in a bowel loop, and that with a day or two's time it might open up on its own. If it didn't, I said, we'd have to talk about possibilities like surgery, Right now, though, we could wait. I was not yet willing to raise the harder issue. I could have pushed ahead, trying to be hard-nosed, and told her that no matter what happened, this blockage was a bad harbinger. Cancers kill people in many ways, and gradually taking away their ability to eat is one of them. But she didn't know me, and I didn't know her. I decided I needed time before attempting that line of discussion. A day later, the news was as good as could be hoped. First, the fluid flowing out of the tube slowed down. Then she started passing gas and having bowel movements. We were able to remove her nasogastric tube and feed her a soft, low-roughage diet. It looked like she would be fine for now. I was tempted simply to discharge her home and wish her well, to skip the hard conversation altogether. But this wasn't likely to be the end of the matter for Douglas. So before she left, I returned to her hospital room and sat with her, her husband, and one of her sons. I started out saying how pleased I was to see her eating again. She said she'd never been so happy to pass gas in her life. She had questions about the foods she should eat and the ones she shouldn't in order to avoid blocking up her bowel again, and I answered them. We made some small talk, and her family told me a bit about her. She'd once been a singer. She became Miss Massachusetts 1956. Afterwards, Nat King Cole asked her to join his tour as a backup singer. But she discovered that the life of an entertainer was not what she wanted. So she came home to Boston. She met Arthur Douglas, who took over the funeral home business after they married. They raised 4 children, but suffered through the death of their oldest child, a son, at a young age. She was looking forward to getting home to her friends and family and to taking a trip to Florida they had planned to get away from all this cancer business. She was eager to leave the hospital. Nonetheless, I decided to push. Here was an opening to discuss her future, and I realized it was one I needed to take. But how to do it? Was I just to blurt out, "By the way, the cancer is getting worse and will probably block you up again"? Bob Arnold, a palliative care physician I'd met from the University of Pittsburgh, had explained to me that the mistake clinicians make in these situations is that they see their task as just supplying cognitive information, hard, cold facts and descriptions. They want to be doctor informative. But it's the meaning behind the information that people are looking for more than the facts. The best way to convey meaning is to tell people what the information means to you yourself, he said. And he gave me 3 words to use to do that. I am worried, I told Douglas. The tumor was still there, I explained, and I was worried the blockage was likely to come back. They were such simple words, but it wasn't hard to sense how much they communicated. I had given her the facts, but by including the fact that I was worried, I'd not only told her about the seriousness of the situation, I'd told her that I was on her side. I was pulling for her. The words also told her that although I feared something serious, there remained uncertainties, possibilities for hope within the parameters nature had imposed. I let her and her family take in what I'd said. I don't remember Douglas's precise words when she spoke, but I remember that the weather in the room had changed. Clouds rolled in. She wanted more information. I asked her what she wanted to know. This was another practiced and deliberate question on my part. I felt foolish to still be learning how to talk to people at this stage of my career, but Arnold had also recommended a strategy palliative care physicians use when they have to talk about bad news with people. They ask, tell, ask. They ask what you want to hear, then they tell you, and then they ask you what you understood. So I asked. Douglas said she wanted to know what could happen to her. I said it was possible that nothing like this episode would ever happen again. I was concerned, however, that the tumor would likely cause another blockage. She'd have to return to the hospital in that case. We'd have to put the tube back in. Or I might need to do surgery to relieve the blockage. That could require giving her an ileostomy, a rerouting of her small bowel to the surface of her skin where we would attach the opening to a bag. Or I might not be able to relieve the blockage at all. She didn't ask any more questions after that. I asked her what she'd understood. She said she understood that she wasn't out of trouble, and with those words, tears sprang to her eyes. Her son tried to comfort her and say things would be all right. She had faith in God, she said. A few months later, I asked her whether she remembered that conversation. She said she sure did. She didn't sleep that night at home. The image of wearing a bag in order to eat hovered in her mind. I was horrified, she said. She recognized that I was trying to be gentle, but that doesn't change the reality that you knew that another blockage was in the offing. She'd always understood that the ovarian cancer was a looming danger for her, but she really hadn't pictured how until then. She was glad we'd spoken, nonetheless, and so was I, because the day after her discharge from the hospital, she started vomiting again. The blockage was back. She was readmitted. We put the tube back in. With a night of fluids and rest, the symptoms once again subsided without need for surgery. But this second episode jolted her because we'd spoken about the meaning of a blockage, that it was her tumor closing in. She saw the connections between events of the previous couple of months, and we talked about the mounting series of crises she'd experienced. The third round of chemotherapy after the previous one had failed, the bad side effects, the pulmonary embolism with its terrible shortness of breath, the bowel obstruction after that, and its almost immediate return. She was starting to grasp that this is what the closing phase of a modern life often looks like. A mounting series of crises from which medicine can offer only brief and temporary rescue. She was experiencing what I have come to think of as the ODTAA syndrome, the syndrome of one damn thing after another. It does not have a totally predictable path. The pauses between crises can vary, but after a certain point, the direction of travel becomes clear. Douglas did make that trip to Florida. She put her feet in the sand and walked with her husband and saw friends and ate the no raw fruits or vegetables diet I'd advised her to eat to minimize the chance a fibrous leaf of lettuce got jammed trying to make it through her intestine. Toward the end of the time, she had a fright. She developed bloating after a meal and returned home to Massachusetts a couple days early, worried that the bowel obstruction was back, but the symptoms subsided and she made a decision. She was going to take a break from her chemotherapy, at least for now. She didn't want to plan her life around the infusions of chemotherapy and the nausea and the painful rashes and the hours of the day she'd spend in bed with fatigue. She wanted to be a wife, mother, neighbor, friend again. She decided, like my father, to take what time would give her, however long that might be. Only now did I begin to recognize how understanding the finitude of one's time could be a gift. After my father was given his diagnosis, he'd initially continued daily life as he always had, his clinical work, his charity projects, his thrice-weekly tennis games. But the sudden knowledge of the fragility of his life narrowed his focus and altered his desires, just as Laura Carstenson's research on perspective suggested it would. It made him visit with his grandchildren more often, put in an extra trip to see his family in India, and tamp down new ventures. He talked about his will with my sister and me, and about his plans for sustaining beyond him the college he'd built near his village. One's sense of time can change, though. As the months passed without his symptoms worsening, my father's fear of the future softened. His horizon of time began to lift. It might be years before anything concerning happened, we all thought, and as it did, his ambitions returned. He launched a new construction project for the college in India. He ran for district governor of Rotary for Southern Ohio, a position that wouldn't even start for another year, and won the office. Then, in early 2009, 2.5 years after his diagnosis, his symptoms began to change. He developed trouble with his right hand. It started with the tingling and numbness in the tips of his fingers. His grip strength gave out. On the tennis court, the racket began flying out of his hand. He dropped drinking glasses. At work, tying knots and handling catheters grew difficult. With both limbs now developing signs of paralysis, it seemed like he'd come to his line in the sand. We talked. Wasn't it time for him to stop practicing surgery? And wasn't it time to see Dr. Benzel about surgery for himself? No, he said. He wasn't ready for either. A few weeks later, however, he announced that he would retire from surgery. As for the spinal operation, he still feared he'd lose more than he'd gain. After his retirement party that June, I braced for the worst. Surgery had been his calling. It had defined his purpose and meaning in life, his loyalties. He'd wanted to be a doctor since the age of 10, when he saw his young mother die from malaria. So now, what was this man going to do with himself? We witnessed an altogether unexpected transformation. He threw himself into his work as Rotary District Governor, whose term of office had just started. He absorbed himself so totally that he changed his email signature from Atmaram Gawande MD to Atmaram Gawande DG. Somehow, instead of holding on to the lifelong identity that was slipping away from him, he managed to redefine it. He moved his line in the sand. This was what it means to have autonomy. You may not control life's circumstances, but getting to be the author of your life means getting to control what you do with them. The job of district governor meant spending the year developing the community service work of all the Rotary clubs in the region. So my father set a goal of speaking at the meetings of each of his district's 59 clubs, twice, and took to the road with my mother. Over the next several months, they crisscrossed a district 10,000 square miles in size. He always did the driving. He could still do that without trouble. They liked to stop at Wendy's for the chicken sandwiches, and he tried to meet as many of the district's 3,700 Rotarians as he could. By the following spring, he was completing his second circuit through the district, but the weakness in his left arm had progressed. He couldn't lift it above 60 degrees. His right hand was losing strength, too. And he was starting to have trouble walking. Up until this point, he'd managed to persist with playing tennis, but now, to his great dismay, he had to give it up. "There's a heaviness in my legs," he said. "I'm afraid, Atul." He and my mother came to visit in Boston. On a Saturday night, the three of us sat in the living room, my mother next to him on a couch and me across from them. I distinctly remember the feeling that a crisis was creeping up on us. He was becoming quadriplegic. "Is it time for surgery?" I asked him. "I don't know," he said. It was time, I realized, for our own hard conversation. "I'm worried," I said. I recalled the list of questions Susan Block, the palliative medicine expert, had said mattered most, and posed them to my father one by one. I asked him what his understanding was of what was happening to him. He understood what I understood. He was becoming paralyzed, he said. What were his fears if that should happen? I asked. He said that he feared that he would become a burden on my mother and that he wouldn't be able to take care of himself anymore. He couldn't fathom what his life would become. My mother, tearing, said she would be there for him. She would be happy to take care of him. Already the shift had started. He was having her do more and more of the driving, and she arranged his medical appointments now. What were his goals if his condition worsened? I asked. He thought on this for a moment. He wanted to finish his Rotary responsibilities, he decided. He would be finishing his term in mid-June, and he wanted to make sure his college and family in India were going to be all right. He wanted to visit them if he could. I asked him what trade-offs he was willing to make and not willing to make to try to stop what was happening to him. He wasn't sure what I meant. I told him about Susan Block's father, who'd also had a spinal cord tumor. He'd said that if he could still watch football on television and eat chocolate ice cream, that would be good enough for him. My dad didn't think that would be good enough for him at all. Being with people and interacting with them was what he cared about most, he said. I tried to understand. So even paralysis would be tolerable as long as he could enjoy people's company? No, he said. He couldn't accept a life of complete physical paralysis, of needing total care. He wanted to be capable of not only being with people, but also still being in charge of his world and life. His advancing quadriplegia threatened to take that away soon. It would mean 24-hour nursing care, then a ventilator and a feeding tube. He didn't sound like he wanted that, I said. Never, he said. Let me die instead. Those questions were among the hardest I'd asked in my life. I posed them with great trepidation, fearing, well, I don't know what. Anger from my father or mother, or depression, or the sense that just by raising such questions, I was letting them down. But what we felt afterward was relief. We felt clarity. Maybe his answers meant that it was time to talk to Benzel about surgery again, I said. My father softly agreed. He told Benzel that he was ready for the spinal surgery. He was more afraid now of what the tumor was doing to him than what an operation might do to him. He scheduled the surgery for 2 months later, after his term of office as district governor ended. By then, his walking had become unsteady. He was having falls and trouble getting up from sitting. Finally, on June 30th, 2010, we arrived at the Cleveland Clinic. My mother, my sister, and I gave him a kiss in a preoperative holding room, adjusted his surgical cap, told him how much we loved him, and left him in the hands of Benzel and his team. The operation was supposed to last all day. Just 2 hours into it, however, Benzel came out to the waiting area. He said my father had gone into an abnormal cardiac rhythm. His heart rate sped up to 150 beats a minute. His blood pressure dropped severely. The cardiac monitor showed signs of a potential heart attack, and they halted the operation. With medications, they got him back into a normal rhythm. A cardiologist said his heart rate slowed enough to avoid a full-blown heart attack, but he wasn't sure what had caused the abnormal rhythm. They expected the medications they'd started to prevent its coming back, but there was uncertainty. The operation was not beyond the point of no return, so Benzel had come out to ask us if he should stop or proceed. I realized then that my father had already told us what to do, just as Susan Bloch's father had. My dad was more afraid of becoming quadriplegic than of dying. I therefore asked Benzel which posed the greater risk of his becoming quadriplegic in the next couple months, stopping or proceeding. Stopping, he said. We told him to proceed. He returned 7 long hours later. He said my father's heart had remained stable. After the early trouble, all had gone as well as could be hoped. Benzel had been able to perform the decompression procedure successfully and remove a small amount of the tumor, though not more. The back of my father's spine was now open from the top to the bottom of his neck, giving the tumor more room to expand. We'd have to see how he woke up, however, to know if any significant damage had been done. We sat with my father in the ICU. He was unconscious on a ventilator. An ultrasound of his heart showed no damage, a huge relief. The team therefore lightened up on his sedatives and let him slowly come to. He woke up groggy but able to follow commands. The resident asked him to squeeze the resident's hands as tightly as he could, to push against him with his feet, to lift his legs off the bed. There was no major loss of motor function, the resident said. When my father heard this, he began gesturing clumsily for our attention. With the breathing tube in his mouth, we couldn't make out what he was saying. He tried to spell what he wanted to say in the air with his fingers. L-I-S? T-A-P? Was he in pain? Was he having trouble? My sister went through the alphabet and asked him to lift his finger when she got to the right letter. In this way, she deciphered his message. His message was happy. A day later, he was out of the ICU. 2 days after that, he left the hospital for 3 weeks in a Cleveland rehabilitation facility. He returned home on a hot summer day feeling strong as ever. He could walk. He had little neck pain at all. He thought trading his old pain for a stiff, unbending neck and a month enduring the hardships of recovery had been a more than acceptable deal. By every measure, he'd made the right choices at each step along the way, to put off immediate surgery, to wait even after he'd had to leave his surgical career, to go ahead with the risks only after almost 4 years, when trouble walking threatened to take away the capabilities he was living for. Soon, he felt, he'd even be able to drive again. He'd made all the right choices. The choices don't stop, however. Life is choices, and they are relentless. No sooner have you made one choice than another is upon you. The results of the tumor biopsy showed my father had an astrocytoma, a relatively slow-growing cancer. After he'd recovered, Benzel referred him to see a radiation oncologist and a neuro-oncologist about the findings. They recommended that he undergo radiation and chemotherapy. This type of tumor cannot be cured, but it can be treated, they said. Treatment could preserve his abilities perhaps for years, and might even restore some of them. My father was hesitant. He had just recovered and gotten back to his service projects. He was making plans to travel again. He was clear about his priorities, and he was concerned about sacrificing them for yet more treatment. But the specialists pushed him. He had so much to gain from the therapy, they argued, and newer radiation techniques would make the side effects fairly minimal. I pushed him too. It seemed almost all upside, I said. The primary downside seemed only to be that we had no radiation facility near home capable of providing the treatment. He and my mother would have to move to Cleveland and put their lives on hold for the 6 weeks of daily radiation treatments. But that was all, I said. He could manage that. Pressed, he accepted. But how foolish these predictions would turn out to be. Unlike Benzel, the specialists had not been ready to acknowledge how much more uncertain the likelihood of benefit was. Nor had they been ready to take the time to understand my father and what the experience of radiation would be like for him. At first it seemed like nothing. They'd made a mold of his body for him to lie in, so he'd be in the exact same position for each dose of his treatment. He'd lie in the mold for up to an hour, a fishnet mask pulled tight over his face, unable to move 2 millimeters as the radiation machine clicked and whirred and delivered its daily blast of gamma rays into his brainstem and spinal cord. Over time, however, he experienced stabbing spasms in his back and neck. Each day the position became harder to endure. The radiation also gradually produced a low-level nausea and a caustic throat pain when he swallowed. With medications, the symptoms became tolerable, but the drugs made him fatigued and constipated. He began sleeping away the day after his treatments, something he'd never done in his life. Then a few weeks into treatment, his sense of taste disappeared. They hadn't mentioned the possibility, and he felt the loss keenly. He loved food. Now he had to force himself to eat. By the time he returned home, he'd lost 21 pounds total. He had a constant tinnitus, a ringing in his ears. His left arm and hand had a new burning electrical pain, and as for his sense of taste, the doctors expected it to return soon, but it never did. Nothing improved in the end. He lost yet more weight that winter. He fell to just 132 pounds. The left-hand numbness and pain climbed above his elbow instead of reducing, as hoped. The numbness in his lower extremities rose above his knees. The ringing in his ears was joined by a sense of vertigo. The left side of his face began to droop. The neck and back spasms persisted. He had a fall. A physical therapist recommended a walker, but he didn't want to use it. It felt like failure. The doctors put him on methylphenidate, Ritalin, to try to stimulate his appetite, and ketamine, an anesthetic, to control his pain, but the drugs made him hallucinate. We didn't understand what was happening. The specialists kept expecting the tumor to shrink, and with it, his symptoms. After his 6-month MRI, however, he and my mom called me. "The tumor is expanding," he said, his voice quiet and resigned. The radiation hadn't worked. The images showed that instead of shrinking, the tumor had kept right on growing, extending upward into his brain, which is why the ringing had persisted and the dizziness had appeared. I welled with sadness. My mother was angry. "What was the radiation for?" she asked. "This should have shrunk. They said it would most likely shrink." My father decided to change the subject. Suddenly, for the first time in weeks, he did not want to talk about his symptoms of the day or his problems. He wanted to know about his grandchildren, how Hattie's symphonic band concert had gone that day, how Walker was doing on his ski team, whether Hunter could say hello. His horizons had narrowed once more. The doctor recommended seeing the oncologist to plan chemotherapy, and a few days later I joined my parents in Cleveland for the appointment. The oncologist was now center stage, but she too lacked Benzel's ability to take in the whole picture. We missed it keenly. She proceeded in information mode. She laid out 8 or 9 chemotherapy options in about 10 minutes. Average number of syllables per drug, 4.1. It was dizzying. He could take bevacizumab, carboplatin, temozolomide, thalidomide, vincristine, vinblastine, or some other options I missed in my notes. She described a variety of different combinations of the drugs to consider as well. The only thing she did not offer or discuss was doing nothing. She suggested he take a combination of temozolomide and bevacizumab. She thought that his likelihood of tumor response, that is, of the tumors not growing further, was around 30%. She seemed to not want to sound discouraging, though, so she added that for many patients the tumor becomes like a low-grade chronic illness that could be watched. "You could be back on a tennis court this summer, hopefully," she added. I couldn't believe she'd really said that. The notion that he might ever get back on a tennis court was daffy. It was not a remotely realistic hope, and I was spitting mad that she would dangle that in front of my father. I saw his expression as he imagined himself back on a tennis court, but it proved to be one of those moments that his being a physician was a clear benefit. He quickly realized it was just a fantasy, and however reluctantly he turned away from it. Instead, he asked about what the treatment would do to his life. "Right now I am foggy in my head. I have tinnitus. I have radiating arm pains. I have trouble walking. That's what's getting me down. Will the drugs make any of this worse?" She allowed that they could, but it depended on the drug. The discussion became difficult for me or my parents to follow, despite all 3 of us being doctors. There were too many options, too many risks and benefits to consider with every possible path, and the conversation never got to what he cared about, which was finding a path with the best chance of maintaining a life he'd find worthwhile. She was driving exactly the kind of conversation that I myself tended to have with patients, but that I didn't want to have anymore. She was offering data and asking my father to make a choice. Did he want the red pill or the blue pill? But the meaning behind the options wasn't clear at all. I turned to my mother and father and said, "Can I ask her about what happens if the tumor progresses?" They nodded. So I did. The oncologist spoke straightforwardly. His upper extremity weakness would gradually increase, she said. His lower extremity weakness would also advance, but respiratory insufficiency, difficulty getting enough oxygen from the weakness of his chest muscles, would become the bigger problem. "Will that feel uncomfortable?" my father asked. "No," she said. "He'd just grow fatigued and sleepy. but the neck pain and shooting pains would likely increase. He could also develop trouble swallowing as the tumor grew to involve critical nerves. I asked her what the range of time looked like for people to reach this final point, both with treatment and without. The question made her squirm. "It's hard to say," she said. I pushed her. "What's the shortest time you've seen and the longest time you've seen for people who took no treatment?" 3 months was the shortest, she said. 3 years the longest. "And with treatment?" She got mumbly. Finally, she said that the longest might not have been that much more than 3 years, but with treatment, the average should shift toward the longer end. It was a hard and unexpected answer for us. "I didn't realize," my father said, his voice trailing off. I remembered what Paul Marceau, Sarah Monopoli's oncologist, had told me about his patients. I'm thinking, can I get a pretty good year or two out of this? They're thinking 10 or 20 years. We were thinking 10 or 20 years too. My father decided to take some time to consider his options. She gave him a prescription for a steroid pill that might temporarily slow the tumor's growth while having relatively few side effects. That night, my parents and I went out for dinner. "The way things are going, I could be bedridden in a few months," my father said. The radiation therapy had only made matters worse. Suppose chemotherapy did the same. We needed guidance. He was torn between living the best he could with what he had versus sacrificing the life he had left for a murky chance of time later. One of the beauties of the old system was that it made these decisions simple. You took the most aggressive treatment available. It wasn't a decision at all, really, but a default setting. This business of deliberating on your options, of figuring out your priorities and working with a doctor to match your treatment to them, was exhausting and complicated, particularly when you didn't have an expert ready to help you parse the unknowns and ambiguities. The pressure remains all in one direction, toward doing more, because the only mistake clinicians seem to fear is doing too little. Most have no appreciation that equally terrible mistakes are possible in the other direction, that doing too much could be no less devastating to a person's life. My father went home still uncertain what to do. Then he had a series of 5 or 6 falls. The numbness in his legs was getting worse. He began losing the sense of where his feet were underneath him. One time, going down, he hit his head hard and had my mother call 911. The EMTs arrived, siren wailing. They put him on a backboard and in a hard collar and raced him to the ER. Even in his own hospital, it was 3 hours before he could get the X-rays confirming that nothing was broken and that he could sit up and take the collar off. By then, the stiff collar and rock-hard backboard had put him in excruciating pain. He required multiple injections of morphine to control it and wasn't released home until near midnight. He told my mother he never wanted to be put through that kind of experience again. 2 mornings later, I got a call from my mother. Around 2 a.m., my father had gotten out of bed to go to the bathroom, she said, but when he went to stand up, his legs wouldn't hold him and he went down. The floor was carpeted, he didn't hit his head and didn't seem hurt, but he couldn't get himself up. His arms and legs were too weak. She tried to lift him back into bed, but he was too heavy. He didn't want to call an ambulance again. So they decided to wait until morning for help. She pulled blankets and pillows off the bed for him and lay down beside him, not wanting him to be alone. But with her bad arthritic knees, she was 75 years old herself, she found she now couldn't get up either. Around 8 a.m., the housekeeper arrived and found them both on the floor. She helped my mother to her feet and my father into bed. That was when my mother called. She sounded frightened. I asked her to put my dad on the line. He was crying, frantic, sputtering, hard to understand. "I'm so scared," he said. I'm becoming paralyzed. I can't do this. I don't want this. I don't want to go through this. I want to die rather than go through this." Tears wet my eyes. I'm a surgeon. I like solving things, but how do I solve this? For 2 minutes, I tried to just listen as he repeated over and over that he couldn't do this. He asked me if I could come. "Yes," I said. "Can you bring the kids?" He thought he was dying, but the hard thing was that he was not. He could be this way for a long while, I realized. "Let me come first," I told him. I set about arranging a plane ticket back home to Ohio and canceling my patients and commitments in Boston. 2 hours later, he called back. He'd calmed down. He'd been able to stand up again, even walk to the kitchen. "You don't have to come," he said. "Come on the weekend." But I decided to go. The crises were mounting. When I made it to Athens early that evening, my mother and father were sitting at the dinner table eating, and they had already turned the 6 hours he spent paralyzed on the bedroom floor into a comedy in the retelling. "It's been years since I've been down on the floor," my mother said. "It was almost romantic," my father said, with what I can only describe as a giggle. I tried to roll with it. But the person I saw before me was different from the one I'd seen just a few weeks before. He'd lost more weight. He was so weak his speech sometimes slurred. He had trouble getting food into his mouth, and his shirt was smeared with his dinner. He needed help standing from sitting. He'd become old before my eyes. Trouble was coming. Today was the first day I really grasped what it would mean for him to become paralyzed. It meant difficulty with the basics: standing up, getting to the bathroom, getting bathed, getting dressed, and my mother wasn't going to be able to help him. We needed to talk. Later that night I sat with my parents and asked, "What are we going to do to take care of you, Dad?" "I don't know," he said. "Have you had trouble getting your breath?" "He can breathe," my mom said. "We're going to need a proper way to take care of him," I said to her. "Maybe they can give him chemo," she said. "No," he said sharply. He'd made up his mind. Even just the side effects of the steroids were proving difficult for him to tolerate: sweats, anxiety, difficulties with thinking and moodiness, and he'd recognized no benefit. He did not think a full-blown course of chemotherapy was going to make any radical improvement, and he did not want the side effects. I helped my mother get him to bed when it got late. I talked with her about the help he was going to need. He was going to need nursing care, a hospital bed, an air mattress to prevent bed sores, physical therapy to prevent his muscles from stiffening. Should we look at nursing homes? She was aghast. "Absolutely not," she said. She'd had friends in the ones around town, and they'd appalled her. She could not imagine putting him in any of them. We'd come to the same fork in the road I have seen scores of patients come to, the same place I'd seen Alice Hobson come to. We were up against the unfixable. But we were desperate to believe that we weren't up against the unmanageable. Yet short of calling 911 the next time trouble hit and letting the logic and momentum of medical solutions take over, what were we to do? Between the three of us, we had 120 years of experience in medicine, but it seemed a mystery. It turned out to be an education. We needed options, and Athens was not a place where anyone could expect the kinds of options for the frail and aged that I'd seen sprouting in Boston. It is a small town in the foothills of Appalachia. The local college, Ohio University, is its lifeblood. 1/3 of the county lived in poverty, making ours the poorest county in the state. So it seemed a surprise when I asked around and discovered that even here, people were rebelling against the way medicine and institutions take control of their lives in old age. I spoke, for instance, to Margaret Cohn. She and her husband Norman were retired biologists. He had a severe form of arthritis known as ankylosing spondylitis, and because of a tremor and the effects of a polio infection in his youth, he faced increasing difficulty walking. The two of them were becoming concerned about whether they'd be able to manage in their home on their own. They didn't want to be forced to move in with any of their 3 children who were scattered far away. They wanted to stay in the community. But when they looked around town for assisted living options, nothing was remotely acceptable. I would live in a tent before I would live like that, she told me. She and Norman decided to come up with a solution themselves, their age be damned. We realized if we didn't do it, no one was going to do it for us, she said. Margaret had read an article in the newspaper about Beacon Hill Village, the Boston program that created neighborhood support for the aged to stay in their homes, and she was inspired. The Cohns got a group of friends together, and in 2009 they formed Athens Village on the same model. They calculated that if they could get 75 people to pay $400 per year, it would be enough to establish the essential services. 100 people signed up, and Athens Village was underway. One of the first people they hired was a wonderfully friendly handyman. He was willing to help people with all the mundane household matters that you take for granted when you're able, but that become critical to surviving in your home when you're not. Fixing a broken lock, changing a light bulb, sorting out what to do about a broken water heater. He could do almost anything. People who joined felt the maintenance guy alone was worth the $400, Margaret said. They also hired a part-time director. She checked up on people and pulled together volunteers who could stop by if the power was out or someone needed a casserole. A local visiting nurse agency provided free office space and a member discount on nursing aid costs. Church and civic organizations provided a daily van transportation service and Meals on Wheels for members who needed it. Bit by bit, the Athens Village built services and a community that could ensure that members were not left flailing when their difficulties mounted. It came not a moment too soon for the Cohns. A year after they'd founded it, Margaret took a fall that put her permanently in a wheelchair. Even with both of them disabled and in their mid-80s, they were able to make staying at home work. My parents and I talked about joining Athens Village. The only other option was home hospice care, and I hesitated to raise it. Its mere mention would drag the dark, unspoken subject of dying onto the coffee table between us. Discussing Athens Village let us pretend what my father was going through was just a kind of aging. But I steeled myself and asked whether home hospice was something to consider as well. My father, it turned out, was willing to contemplate hospice, my mother less so. "I don't think it's necessary," she said. But my father said that maybe it wasn't a bad idea to have someone from the agency tell us about it. The next morning, a nurse practitioner from the Appalachian Community Hospice stopped by. My mother made some tea, and we sat around our dining table. I will confess to expecting little of the nurse. This wasn't Boston. The agency was called Appalachian Community Hospice, for God's sake. The nurse blew me away, though. "How are you?" she said to my dad. "Do you have a lot of pain?" "Not right now," he said. "Where do you get the pain?" "In my neck and in my back." With that opening, I realized she had established a few things. She made sure he was in a state of mind to talk. She made instantly clear that what she cared about was him and how he was doing, not about his disease or his diagnosis. And she'd let us know that, surrounded by a bunch of doctors or not, she knew exactly what she was doing. She looked to be around 50, with short, cropped gray hair, a white cotton sweater with an embroidered rose across the front, and a stethoscope sticking out of her bag. She had a local country accent, and with it, she got right to the point. "They sent me out with hospice papers," she said to my father. "What do you think about that?" My father didn't say anything for a moment. The nurse waited. She knew how to be silent. "I think it may be best," he said, "because I don't want chemo." "What kinds of problems are you having?" "Nausea," he said. Pain control, grogginess. The medicine makes me too sleepy. I've tried Tylenol with codeine. I've tried Toradol pills. Now I'm on ketamine. He went on. I woke up this morning and it was a big change. I couldn't stand up. I couldn't push the pillow up in the bed. I couldn't handle a toothbrush to brush my teeth. I couldn't pull my pants or socks on. My torso is becoming weak. It's getting hard to sit up. Hospice is about palliative care, she said, about giving care to help manage these difficulties. She went through the services that Medicare would cover for my father. He'd have a palliative care physician who could help adjust medications and other treatments to minimize his nausea, pain, and other symptoms as much as possible. He'd have regular nursing visits, plus emergency nursing support available 24 hours a day by phone. He'd have 14 hours a week of a home health aide who could help with bathing, getting dressed, cleaning up the house, anything non-medical. There'd be a social worker and a spiritual counselor available. He'd have the medical equipment he needed. And he could revocate, drop the hospice services at any time. She asked him if these were services he'd like to start now or think about. Start now, he said. He was ready. I looked at my mother. Her face was blank. The nurse practitioner got into the nitty-gritty. Did he have a DNR? A baby monitor or a bell for him to summon a caregiver? A 24/7 presence in the house to help? Then she asked, "What funeral home do you want to use?" And I was divided between shock, are we really having this conversation, and reassurance at how normal and routine this was to her. Jaeger's, he said without hesitation. He'd been thinking about it all along, I realized. My father was calm. My mother, however, was stunned. This was not going where she'd been prepared for it to go. The nurse turned to her and, not unkindly, but nonetheless all too clearly said, "When he passes away, don't call 911. Don't call the police. Don't call an ambulance company. Call us. A nurse will help. She will discard the narcotics, arrange the death certificate, wash his body, arrange with the funeral home." "Right now we're not thinking of death," my mother said firmly, "just paralysis." "Okay," the nurse said. She asked my father what his biggest concerns were. He said he wanted to stay strong while he could. He wanted to be able to type, because email and Skype were how he connected with family and friends all over the world. He didn't want pain. "I want to be happy," he said. She stayed almost 2 hours. She examined him, inspected the house for hazards, sorted out where to place the bed, and figured out a schedule for the nurse and the home health aide to visit. She also told my father he needed to do just 2 main things. She figured out he'd been taking his pain medications haphazardly, tinkering with which drug he took at what dose, and she told him he needed to take a consistent regimen and log his response so the hospice team could gauge the effect accurately and help him find the optimal mix to minimize pain and grogginess. And she told him that he needed to no longer attempt to get up or around without someone helping him. "I'm used to just getting up and walking," he said. "If you break your hip, Dr. Gawande, it will be a disaster," she said. He agreed to her instructions. In the days that followed, it astonished me to see the difference the hospice's 2 simple instructions made. My father couldn't resist still tinkering with his medications, but he did it much less than he had, and he kept a log of his symptoms and what meds he took when. The nurse who visited each day would go over it with him and identify adjustments to make. He'd been oscillating wildly, we realized, between severe pain and becoming so drugged he seemed drunk, with slurred, confused speech and difficulty controlling his limbs. The changes gradually smoothed the pattern. The drunken episodes all but disappeared, and his pain control improved, although it was never complete, to his great frustration and sometimes anger. He also complied with the instructions not to attempt to get around without help. The hospice helped my parents hire a personal care aide to stay overnight and assist my father to the bathroom when he needed it. After that, he had no more falls, and we gradually realized how much each one had set him back. Every passing day without a fall allowed his back and neck spasms to reduce, his pain to become better controlled, and his strength to increase. We witnessed for ourselves the consequences of living for the best possible day today instead of sacrificing time now for time later. He'd become all but wheelchair-bound, but his slide into complete quadriplegia halted. He became more able to manage short distances with a walker. His control of his hands and his arm strength improved. He had less trouble calling people on the phone and using his laptop. The greater predictability of his day let him have more visitors over. Soon, he even began hosting parties at our house again. He found that in the narrow space of possibility that his awful tumor had left for him, there was still room to live. 2 months on, in June, I flew home from Boston not only to see him, but also to give the graduation address for Ohio University. My father had been excited about attending the convocation from the moment I had been invited a year before. He was proud, and I had envisioned both my parents being there. Little is more gratifying than actually being wanted back in your hometown. For a while, however, I feared my father might not survive long enough. In the last few weeks, it became apparent he would, and the planning turned to logistics. The ceremony was to take place in the university's basketball arena with the graduates in folding chairs on the parquet and their families up in the stands. We worked out a plan to bring my father up the outside ramp by golf cart, transfer him to a wheelchair, and seat him on the periphery of the floor to watch. But when the day came and the cart brought him to the arena doors, he was adamant that he would walk and not sit in a wheelchair on the floor. I helped him to stand. He took my arm, and he began walking. I'd not seen him make it farther than across a living room in half a year, but walking slowly, his feet shuffling, he went the length of a basketball floor and then up a flight of 20 concrete steps to join the families in the stands. I was almost overcome just witnessing it. Here is what a different kind of care, a different kind of medicine makes possible, I thought to myself. Here is what having a hard conversation can do.